Okay, so let's start off again. First was, see, in we can get three possibilities. Okay, if there's neck rigidity and photophobia, then it will be meningitis. Whenever there's altered mentation, there is encephalitis. Okay, see, I'm talking about this corner. Okay, so headache, vomiting, fever, DDs. Okay, and whenever there's focal needle deficits, obviously you'll have an abscess. So so basically what you have, increased ICP. If you have, obviously papilledema is this thing of increase. Again P fails. Okay, so P was what? Okay, P was, we had papilledema, F for focal neurological deficits, A for altered mentation, I was for immunocompromised. Okay, and immunocompromised means you can have HIV also. Okay, here all these things imaging will be done before lumbar puncture. Okay, I is done, L is lesion, any kind of space occupying lesion or anything, and then we have seizures. As for seizures, okay, even local infection and decreased PTINR, that also we won't do. Okay, these are all indications of imaging before lumbar puncture. So so basically what happens is, so we had this stiff neck, all this. Now when we have raised ICP, okay, when we have a TB patient, so basically the TB patient, hepatic encephalopathy, we have to give ATT. Okay, in that case, all right. And obstructive hydrocephalus, you have to do an MRI. Okay, and yeah, that is done. And CT, because NCCT is basically cerebral edema. Okay, NCCT is for cerebral. Next, now let's see steps of lumbar puncture. So we saw the layers is done. Okay, supra, intra, supra, inter and ligamentum flavum, supra, inter and ligamentum flavum, and what was it? L1, L2, S2. S2 was subarachnoid space ending. L2 was spinal cord ending. Okay, L1, L2, and L3, L4, and then finally L5, S1 was infants. Okay, next we have this. Okay, so positions preferred overall, obviously left lateral. Obese pregnant patient. Okay, CSM manometry, and what are the this thing. So first cleaning and dripping, then we'll get the anesthetic. Beveled edge up. Okay, beveled edge parallel to the longitudinal dural fibers, this line. Okay, so beveled edge parallel to longitudinal dural fibers, trajectory durator slightly rostally, that is towards the umbilicus. Okay, like this is the this thing now, so slightly rostrally. Remember we had rostral neuropore, anencephaly. Okay, so rostrally. Alright, so rostrally towards the umbilicus. Okay, needle patency confirmed and connection with the manometer stopper. Opening pressure is more than 240. Cook in the test suspected for arachnoid block. Okay, pressing jugular veins, and then ICP is raised, and it's not done. Okay, it's not done anymore. Quick in the test is basically subarachnoid block. On pressing jugular veins, you basically have raised ICP, and because of that, CSF pressure is also raised. More CSF comes out from the thing, and if not, then that means there is obstruction. Okay, if this on pressing the jugular veins, if you don't have this raising, okay, then you get obstruction. What is Miller-Fisher test in NPH? Okay, normal pressure hydrocephalus, CSF tap of 40 ml, relief of symptoms, gait improves rapidly is Miller-Fisher test. Miller-Fisher test, 40 ml CSF tapping. What are the CSF markers? Okay, so choriocarcinoma, you have HCG, meningioma is spermine, leukemia is polyamine, and glioma is demosterol. And MS का investigation of choice, MS is multiple sclerosis investigation of choice is CEMRIC. 18 to 20 gauge is for manometry. Now lumbar puncture needles. Okay, so Tuftier's line, okay, that is the intercrystal line, we consider that. Okay, so Tuftier's line is the intercrystal line, this Tuftier's line. Okay, next is dura cutting and dura splitting. So Quincke's has K on it, K, so Quincke, so cutting. Okay, and rest two, Whittaker and Sprotty is going to be dura splitting needles. Pencil tip incision, first incision of the skin, first you have to give the incision of the skin and subcutaneous tissue, and then you have to insert this. Okay, this comes as, obviously instruments ka this thing. So Quinkies, this looks like a Q. Okay, Whittaker is the square one. Okay, square, and Sprotty is goal. Next, all this is done. HCG, okay, again, HCG is choriocarcinoma, spermatitis meningioma, polyamine is leukemia, and dermastral is going to be glioma. And that's it, obviously, MS investigation of choice. 18 gauge to 20 gauge, manometry. 22 gauge is diagnostic tab. 22 gauge is diagnostic tab. 18 to 20 gauge is going to be this thing. Okay. So 25 and 26 gauge. So 18 is done. 18 and 20 is going to be pink. Pink and yellow. This is going to be, I don't know how to remember this, but I don't know whether we have to remember this or not. No, not necessary. Just 25, 26 gauge. That is orange and brown. This is going to be for spinal anesthesia. Okay. Done. Just orange in this thing. Here, see, here is different from the cannulas. It is opposite to the cannulas. Okay. Orange in cannulas was orangutan. Okay, that was 14. And here it is orange is 25 gauge. Okay, and here you basically have this thing, brown is 26, brown is 26, 25 is orange. This is used in spinal anesthesia. 18 gauge is manometry, means pink and yellow is used for manometry, and 22 gauge is diagnostic tab. 22 gauge is always the most wherever it is used. Okay, next is CSF analysis. So this is one of the most important tables. Okay. So first, without going over this at all, okay, first I'll just not look at this and just keep on saying, while you people are there to check whether I'm saying right or not, whether I'm recalling rightly or not. So first we have normal, okay, and we have color WBC protein and this. Okay, so normal may, it's all going to be clear. Okay, bacterial, what happens is WBCs is mainly neutrophils, and glucose it will be decreased, proteins it will be increased obviously, and opening pressure will also be increased. Viral WBCs will mainly be lymphocytes, and glucose it will be glucose it will, I think, remains the same. Okay, and no, glucose proteins will be increased while opening pressure is this thing increase. Fungal may obviously TB may you'll have colored. Okay, TB may you'll also have lymphocytes. Okay, that is also important. Okay, GBS may you have albuminocytological mismatch or something, and oligoclonal bands is present in MS. Okay, so rest all normal. Okay, so fungal, this something that I always miss out on. Okay, let's see. So turbid all this is fine. This is decreased. Obviously, this is increased. Opening pressure is increased here. Okay, so this is important. Now normals is very important. Normals is 0 to 5, 40 to 70, less than this thing. Now glucose. Okay, see, everywhere glucose is decreased except in case of viral where you have normal. Okay, they don't eat the glucose. Alright, proteins mein everywhere is increased except viral and fungal where it is plus minus. Okay, it can increase, it can decrease. In this also it is minus, which fungus can eat, cannot eat. Okay, next is obviously polymorph lymphocytes of this. Okay, fungal is not highest TB. This is turbid, obviously bacterial will be turbid, is turbid, and cobweb, coagulum is important, clear, all this is okay. Rest all in case of MS is normal, alveolar cytological dissociation, and oligoclonal bands. These are the two this thing. Next is opening pressure hydrocephalus. Okay, sorry. What am I saying? Opening pressure is 50 to 180. Okay, now this thing adenosine deaminase and chloride in case of bacterial meningitis, it is going to be increased. Okay, so bacterial may ADA and chloride. In case of TB, we are going to have IF and gamma increased. Okay, the levels, and in this opening pressure obviously normal to high, normal to normal. Okay, in this is normal, in this is normal to high. So fungus and this thing goes side by side. Okay, just remember the nature of the fungus. The fungus has so much of this thing, that's why it utilizes glucose. And cryptococcal meningitis, except liquid cryptococcal meningitis, in this case it is increased. So fungus is usually normal, but in case of cryptococcal meningitis the opening pressure is increased. Bacterial and TB both is going to be increased only. Next is this blood culture, empirical anti. Okay, blood culture, if this we get to see, what do we do? antibiotic. Okay. Adjunctive dexamethasone therapy we can give in bacterial meningitis. Adjunctive dexamethasone therapy can be given in bacterial meningitis. Okay, so bacterial meningitis you can give adjunctive dexamethasone therapy. In case of TB, okay, we have to give the ATT and adjust means adjuvant glucocorticoid therapy. So here dexamethasone, here glucocorticoid. This is usually, especially in young and HIV, we can give ATT and adjunctive glucocorticoid therapy. And the most sensitive is latest agglutination card test. In case of cryptococcal meningitis, most sensitive. See, the India Inc. is one of the this thing, but the most sensitive is latest agglutination card test. Cryptococcal meningitis. Cryptococcal meningitis. Okay. Systemic fungi. Okay. What is Freund syndrome? Freund syndrome is spinal obstruction. CSF becomes exudator, coagulates on tap. Okay, that is Freund syndrome. And xanthochromia, when do we have xanthochromia? That is RBC on tap. That will be yellow in color. Okay. So that is then. Next is this part. Not very this thing, but then see cross sections. In the new first aids, you do have some cross sections. Okay. So the only question that has come from cross section once was that red nucleus at the level of the, I guess it was superior colliculus. So that basically third nerve. So which nerve will go or something like that. Okay, whatever. See here what happens is lumbosacral legs are lateral. Lumbosacral legs are lateral. So that's why this way you basically have. Okay, legs are lateral in all this, lateral corticospinal and spinothalamic. Okay, and dorsal column is basically hands by the side, arms outside and legs inside. So okay, this is with stain. This was with stain, I forgot. Okay, central canal, lateral, all this is okay. Intramedial L1 and L2. Now, obviously, here you basically have to imagine that the person is standing in the middle and having his arms outstretched. So that's why it's cervical, thoracic, lumbar, and sacral. Okay, and here it is basically this is sacral is lateral. Okay, here is just medial to lateral. That's why lateral sternothalamic tract. Okay, so this is done. Obviously, dorsal column, fasciculus gracilis, and fasciculus cuneatus. Okay, so gracilis is medial and cuneatus is lateral. All right, and here we have lateral spinothalamic tract, obviously pain, temperature, and this is like this. Okay, so okay, anterior lateral is pain and temperature, anterior is screw touch and pressure. Okay, so anterior has all A delta fibers, lateral would have C fibers, means kind of according to the Erlanger classification. All right, LPT, pain and temperature, and anterior is screw touch and pressure. Okay, so lateral spinothalamic tract, syrinx, syringomelia. Okay, cape like loss of sensation. Descending, this is your descending lateral. This is corticospinal tract. This is also sacral. See, front wala whatever is there, it is all sacral lateral. Okay, it's all gonna be lateral. Everything lateral has sacral lateral. All right, and another this thing is anterior corticospinal tract. It sends us straight into the medulla, and 20% does not cross, and 80% that crosses. Okay, when it crosses at the level of the medulla. Okay, so forget that, all that. Now we come to this. This is quite significant. Okay, and this entire page, actually there's a new this thing in first aid, the new editions. So this is important. Okay. Okay, so first, what do we have? Spinal thalamic pain and temperature, dorsal column pressure, all this cortical. Main thing is A delta. A delta was what? Yeah, A delta and C fibers. A delta was all temperature. Okay, A delta was temperature. Local anesthetic, what is the order? A delta, A gamma, then A alpha, A beta, then after it is B and C. That was local anesthetic tolerance, this thing, sensitivity ka order. Okay, so here what happens? Spinothalamic basically crosses the first order neuron, crosses the level of the, or it crosses the level of the this thing. First order neuron you basically have obviously from the posterior, and then it enters. See, this is sensory, right? So it is entering from the dorsal root ganglion. Okay, dorsal part, alar plate, sad. Okay, sensory, alar plate, dorsal. Okay, so this is like entering from the dorsal part, and it decussate in the spinal cord itself, the second order neuron. Okay, dorsal horn is going to come into the spinal cord. Dorsal root ganglion, say that pseudo unipolar neuron, that is the first order neuron. Okay, so pseudo unipolar neuron, that is the first order neuron, that is going to come in the dorsal. Okay, I don't know why. Oh, see, this is a bit bad quality, this thing, because I had taken a screenshot from the first aid, this thing, the new first aid. So just bear with me. Spinothalamic, the first order neuron is the dorsal root ganglion. Okay, so that is going to enter the spinal cord and is a pseudo unipolar neuron. The second order neuron is in the posterior horn. Okay, so obviously this is dorsally present. First synapse is going to be present in the dorsal horn, and then after that it is going to decussate in the spinal cord. Okay, and then ascending contralaterally, and obviously ventroposterolateral thalamus, and the third order neuron, it projects to the somatosensory cortex. So if we have to make a this thing, so it is coming through the dorsal horn. See, coming through the dorsal horn, then after it is coming through, it is coming to the dorsal horn of the spinal cord, dorsal root ganglion, dorsal horn of the spinal cord. That till there is the first order nucleus. Then from the dorsal root ganglion, I mean dorsal horn of the spinal cord, there is going to come the second order neuron comes, and then it crosses over anterior white commissure. Okay, crosses over the anterior white commissure. That's why whenever you have syringomelia, you have both sides there is loss of sensation. Okay, because it crosses the level of anterior commissure, and then it ascends upwards in the medulla. Okay, ascends upwards, and then at the VPL third order neuron. Okay, third order neuron is at the VPL. So first order neuron, first synapse is at the dorsal horn, second synapse is at the VPL. Okay, ventroposterolateral nucleus of the thalamus. Okay, so ventropostural, yeah, it takes from the VPL, also takes from the this thing also. VPL same. It is VPL is the same for dorsal column also. Okay, for dorsal column also we have VPL. For lateral spinothalamic tract also we have VPL for the spinothalamic tract. Okay, so that one was ascending contralaterally, spinothalamic. Okay, dorsal column, what happens? Pressure, vibrations, and all this we know. Obviously, it's a sensation, so it's going to come to the dorsal root ganglion. All this is fine. Next is most important. It ascends directly upwards. Okay, this just comes and it goes to the white column of the spinal cord. That is nucleus gracilis. I mean fasciculus gracilis and fasciculus cuneatus. Okay, and then it goes straight to the medulla, and the first synapse takes place. Okay, means it ascends at all the is it ascends at the as the it ascends, and then after the first synapse takes place in the medulla. Okay, so in the medulla you have the two nuclei. Okay, nucleus cuneatus and nucleus gracilis. Okay, corresponding to the fasciculus cuneatus and fasciculus gracilis. So that nucleus gracilis nucleus ipsilateral medulla. Okay, same side ka medulla, it will come ascend, and then at the medulla there is going to be a decussation, and then it is going to form the medial lemniscus. So the decussation here is going to be at the medulla level. There it was at the anterior commissure of the spinal cord. Okay, and it will cross over at the medulla level, and then it will ascend as a a structure called medial lemniscus. Okay, so medial lemniscus is a part of the dorsal column. Okay, and then it will again go to the VPL of the thalamus, and there the second this thing will take place. Okay, and obviously somatosensory cortex. Now the most important thing that you have to realize in lateral and in the spinothalamic tract and the dorsal column is basically the second synapse is taking place at the thalamus. The only difference is, and the first order nucleus is coming from the dorsal root ganglion only. Okay, the only difference here is the decussation. Okay, so the first decussation is taking place at the anterior white commissure, that is the lateral spinothalamic tract, and the second one is taking place in the medulla, and that's why it's ascending as the medial lemniscus. The the spinothalamic tract that goes as the spinal lemniscus, I think. Okay, next we have is the corticospinal tract. So corticospinal tract, what does that do? That also crosses over at the level of the medulla only. So here, but then you have the motor fiber. So motor is what? That was basal plate. Okay, basal plate of the spinal cord, motor. So that's why here anterior horn. Okay, the first there it was the posterior horn. In case of lateral, the first synapse was taking place at the posterior horn. This is just the opposite. It will take place at the anterior horn. Okay, anterior horn. Then from the anterior horn, there'll be some fibers go upwards and then have a pyramidal decussation, and there's no this thing, and then straight away it'll go to the this thing. Okay, so second synapse, so basically first synapse, okay, is at the neuromuscular junction. In case of, okay, in case of this, in case of corticospinal tract, what happens first? Obviously motor cortex ipsilaterally decussates at the caudal medulla, all this is okay. And okay, first synapse is obviously anterior horn. Second synapse is element, it leaves the spinal cord, and then lastly the second synapse we also have the NMJ. Okay, oh no, I was going in reverse order, sorry. This comes down like this. Okay, oh my god. Okay, this comes obviously down like this. Actually I was just going sensory, so that's why I got mixed up. Okay, so obviously the first order neuron is coming down like this. Okay, it is coming from the medulla and directly coming to this. Okay, these are all the upper motor neuron. Okay, so it is coming, and it is coming straight to the anterior horn, and then after that second one is the second order neuron is from the anterior horn to the neuromuscular junction, and the last this thing. Okay, so it leaves, and then you have the neuromuscular junction synapse, that is the second synapse. Okay, so the first synapse itself is taking place in the anterior horn in case of the corticospinal tract, and the second synapse is taking place at the neuromuscular junction, but because it is coming down. Motor. Next we have the reflexes. Okay, so this mainly comes in the this thing. Okay, Moro's reflex, this it's better that you do it from pediatrics, not very well given here, but then yeah, you can. Okay, just the definitions you can take it from here, and the age and the timeline, pediatrics. Okay, so actually its reflex is S1 S2, that is okay. Patellar L2 L4, kick the door. C5 C6 faces, C6 C7 laser strip triceps. Another additional this thing, C5 is jaw jerk, we had seen that over there. Masseter muscle. Okay, finger flexion is C8, hip flexion is thigh abdomen, L4 L5 S1 S2. Another important this thing is cremasteric is L1 L2. Okay, so this is with genitofemoral nerve, so this has come. Cremasteric reflex, you have the genitofemoral nerve, femoral is afferent and genital is efferent. Okay, so femoral, genitofemoral we say, but just go backwards. Here femoral is afferent and genito is going to be efferent, L1 L2, and anal wing is S3 S4. Okay, S3 S4. Okay, so this This is the reflex grading and all, not very this thing. Now, see, this man is also good, that you have C5. Okay, cranial nerve 5 is Georgia. Cranial nerve 5. C5, C6 is, you're saying, biceps. Then C6, C7 is the triceps. Okay, then L2, L3, L4, it is in the thigh. So that's why till here is the patella, and S1, S2, it should be the Achilles heel. Okay. Anyways, this has a good mnemonic in this thing only, in YouTube. On YouTube itself, there's a good mnemonic for this. Anyways, I think I'll find the mnemonic and come back again. Okay, wait, I'll just go take my that copy. Okay, so let's try and make a mnemonic out of this and see whether we can do something about this. Okay, so first is we have first biceps. Okay, so biceps is 2. Okay, so biceps basically. So we have two this thing, two nerves. Okay, that is C5, C6. Okay, even if you remember the root value, like musculocutaneous nerve ka root value, then also it will happen. Okay, so C5, C6. Okay, you have biceps. Bi means 2, so that's why you have two values, that is C5 and C6, so 2. Next is triceps. So after biceps, obviously, if we remember the root value, C6, C7, C8. Okay, so triceps C6, C7, C8. Okay, three structures, so C6, C7, C8. Okay, so biceps C5, C6, two root values. Triceps C6, C7, C8. Okay, that is this thing. Next, okay, so I was thinking seps and six rhymes kind of so, but then not. Yeah, we can actually see triceps, keep it as C6 sir, C7 sir. Okay, so we can keep it like that. Okay, so triceps is 3, C6, C6, C7, C8. Biceps is 2, C5, C6. Even if you remember C5, C6, then consecutively you know that yahi se continue karna hai. Here, from here only we have to continue, that is C6, C7. So C6, C7, C8 in continuity with this becomes a triceps reflex. Next is patellar. So, okay, so biceps done, triceps done. Next is knee. Okay, so knee, there are Knee, there are 4 letters. Like when you say knee, don't say patellar reflex, say knee reflex. Okay, so first is knee. Knee is where? Lower limb, so L. Okay, L for lower limb, L for knee. And then you have knee. Don't say patellar reflex, say knee reflex. So knee is 4 letters. So basically 2 E's and then L4. Okay, so 4 E's. Okay, so L2, L3, L4. Okay, because the word knee has 4 letters, so that's why 4. Okay, and knee is in the lower leg, so L. Okay, so L2, L3, L4. Okay, kind of this way. Okay, so biceps, 2 root values we have. Okay, that is C5, C6, and triceps is in continuity with that with 3 root values, that is C6, C7, C8. And knee, how will we remember that? Knee was 4 letters, so 4 letters, L4, because knee is in the lower limb, so L2, L3, L4. Okay, next we have ankle. Okay, now A, C, we know that that is going to be S sacral. Okay, so we know that it's going to be sacral only. Now sacral what? The number. Okay, so A is the first letter, so that's why A, S1. Okay, so S1, S2. A is the first letter, so that's why S1, S2. Next, we have superficial reflexes. Okay, so these were these are the deep tendon reflexes. Another one is your cremasteric. Okay, so cremasteric, how will we remember? Okay, um, this is a very this thing, cream laga. ठीक है, cream laga and then it becomes L. ठीक है, तो L1 cream laga. Okay, and anal 4 letters, so that's why 4, S4. Okay, anal 4 letters, that's why knee 4 letters, that's why L4. And anal S4, S3, S4, 4 letters. Okay, and another one, this thing. Okay, now let's go ahead. This moros is simply hang for life. Okay, just abduct and extend the arm and startle and then draw together. All this though is fine. Okay, this is not required. Okay, Babinski, UMN lesion. That's it. Just the properties of Babinski. What all happens? Dorsiflexion of the large toes and fanning of the other toes with plantar stimulation. That is Babinski. Okay, and there are 2-3 others also, but then later on. And this gallant reflex is the new one. Stroking one on the side by the newborn in the ventral suspension position face down causes lateral flexion of the whole body towards lateral flexion of the whole body towards the stimulated side, that is GAN. Okay, gallant reflex. Now this particular this thing, so C2, C3. Okay, C2 posterior half of the skull, posterior half of the skull. Okay, so C2 posterior half of the skull. C3 matlab high turtleneck shirt, so that's why you have C3, C4, C5, all the diaphragm. Okay, so diaphragm and gallbladder pain referred by a phrenic nerve. Okay, C4 low collar shirt, fine. Okay, and because here it is. Okay, next is at the sternal notch is C4, and next is C6 is so C3 has come to some extent. C4, C3, C4 they had asked. Okay, that it is neckline with C3, and C4 is going to be that low collar shirt or whatever. C6 very old needs. Okay, next is C6 includes thumb. So when you do thumbs up, it looks like a 6. So that's why C6. Okay, C6 because it looks like the thumb. T4 level of the nipple, very important. Okay, pore, teeth pore. So T4, T7 is the avoid process, 7 letters. XI, PHOID, 7 letters, and T10 is at the belly button. So this T4 and T7 has more possibility of is more volatile because T10 umbilical everyone remembers early appendicitis pain. L1 inguinal ligament, see this is L1. Okay, L1. What was L4? Knee. Okay, so L4 obviously knee. KNEE, that is the reflex. Okay, also S2, S3, S4 external alien sphincter. Okay, it this thing keeps when basically this is all your sympathetic nerve supply, so that's why erection. Okay, another very important S2, S3, S4 is also bulbar cavernosus reflex. Okay, so BCR, if you like think. Okay, BCR. So the mnemonic was that B is the second letter, so B, C is the third letter, and R char. R means char in Hindi. R char. So 2, 3, 4. B bulbo cavernosus reflex. Okay, so BCR. Okay. Next is next we can just look at this diagram and see some important points. This was neckline, and oh, this takes a bit of time. Okay, so neckline, C4 is the sternal notch, that is the sternal angle is T4, T2 is the sternal angle. Okay, and that was the sternal notch, and this side was the nipple. Xiphisternum is T6, Xiphisternum is T7. Okay, and because there were 7 letters, and T10 is going to be the umbilicus. Okay, S2, S3, S4, that is done. Okay, lower thighs L3. Okay, so this is another this thing. Lower thighs medially we have L3. Okay, L4, this is how it goes. Okay, so lower thighs. Okay, just now thighs. When you say thighs, lower thighs, thrice 3. So L3. Okay, now S1, this is something that can come because they say कि web of the first web को कौन supply, who supplies the first web. Okay, so medial foot L4, fine. Okay, S1, just remember sole, S1 single. Okay, so single people little. Okay, so single little sole finger. Okay, S stands for single sole little, and sole means one, so one. ठीक है, S1. Next, also you can remember it this way also, कि this is a very a bit this thing mnemonic. See, what happens is whenever hand का little finger is the indication of whenever you want to go to the toilet. Okay, so toilet में हमेशा अकेले ही जाते हैं. So whenever you go to the toilet, you go alone. So that's why sole S. Okay, so little finger 1. ठीक है, kind of like that. You can remember that it supplies the sole. Okay, and the little finger. Next is fur. Okay, so 5, L5 is first web L5. Okay, fur in Hindi 5. Okay, so L5, so first web space. So fur 5, first web space, so L5. Okay, L है we are in the leg, so L5. Alright. Okay, now another very important this thing. Okay, the saddle area was around the anal wink. It was S2, or it was, oh, this is one mistake that I always do. So it always, so saddle, it grows outwards. Okay, so grows outwards. Wait a second, I think what did I do? Okay, forget this. Okay, see, out. Okay, I had made this new one, and out you can say 2. Okay, this is INICET stuff. So out 2, you have to remember this, and we can say it increases inwards. Okay, don't remember this. This is stupid mnemonic. Just the fact that it goes inwards. Okay, so out t. Okay, out t, we have the t sound, so it's 2, S2. Okay, so then it goes S2, S3, S4, S5. Okay, so S2, then S3, then S4, and then finally around the this thing in is S5. Okay, so innermost is the S5. So this is first affected in conus, and this is in the perianal region. So very important. Okay, so that was in the perianal region. Okay, anal reflex we had S4, no? S4 was the anus. So just remember S2, 2, T was the outermost. Okay, that is in the thighs. So 2 say now you're going inwards. When you go inwards, then is 2, 3, 4, 5. Okay, when you go inwards. First is 2, this is 2, this is 3, this is 4, and finally this is 5. Okay, so this is done. Okay, it can be very difficult to remember, but then yeah, we have to. And this was S3, S4, see, anal wink. 4, 5 was the innermost, S3, S4 was just outside it. Okay, so I think this is okay. Next is this table, okay, which ma'am had basically given. So let's see this quickly. Okay. Okay. Table L2, L3, I told you thigh. Okay, so that is that knee extension. Okay. One more thing, what happens when you go from L2 to S, okay, like L2, L3, S4. Just look at this table. If you go from L2 to S1, S3, S1, S2, S3, S4, S5, okay, you always have a alternating action. Okay. First is flexion, then is extension, then again is flexion, then is extension, again is flexion, and then you have this finger. Okay, so that is one thing. That's how you can remember the actions. So L2, upper thigh. Okay, and okay, so first you remember this alternating action. This is the first thing to be remembered. Okay, the second thing to be remembered was the mnemonic for L3, that was thigh. You say lower, L for lower, 3 for thigh. So obviously above that would be upper thigh, that is L2. Okay, and below that will be medial leg. Okay, whatever. And L5 was fur, that is dorsum. This is important, dorsum of the first web. Okay, first say 5. Okay, and S1 obviously was sole, that is little finger. Okay, and S3 are perineal region, 5 was the innermost. Okay, so those are the main points that we remembered. So obviously upper thigh hamesha, this is going to be hip flexion. Okay, and we had cremasteric reflex. Okay, cream laga, so L. Okay, number 1 cream laga le. Okay, something like that. And L1, L2. Okay, so L3 knee extension, knee 3, that also you can say knee 3. Okay, knee 3 भी बोल सकते हो. See, knee 3 is rhyming. Knee 3 lower thigh. Okay, that way you can pronounce. And knee is going to be 4 letters. So L3, L4, that was the patellar reflex. So L3, L4 was the patellar reflex. This is not very important. Okay, L5 for first web space. Okay, first web space, obviously first finger is what? Extensor hallucis longus. So we had hip flexion, knee, dorsiflexion, and then finally extensor hallucis longus. Okay, because L5 is first web space, dorsum of the foot. Okay, so dorsum of the foot is extensors. Okay, so means that side, dorsum of the foot. Okay, so basically there, or no, I think you have flexor. So basically अच्छा ठीक है, रहने दो. I'm not gonna crack my brains too much. Okay, here next is obviously, because dorsum of the foot, when you're saying, that is mainly the dorsiflexion they do na. So fine, whatever. Okay, next is S1, S2. This is all from MERS. Okay, MER, it is from MER. And S1, S2, we have sole, little toe, flexor hallucis longus, that is the little toe ka flexor. We have to see this, this, don't pay attention to this too much. Aega bhi nahi, okay, much, but yeah, just check this. I'll check this. Okay, S3, S for the sphincter, that is the perianal area. So we had the BCR, bulbocavernosus reflex. So B was supposed to be S2 because the second letter. So B, C, S3, R, 4. Okay, so that is done. Now is this. Okay, so this in the morning also we I had revised the parts of the brain. Okay, I mean the Broadman's area. Okay, so now after this we're gonna have a good one, means a challenging session. Okay, because this is going to be all the stroke, aphasia, and everything. Okay, so let's pause, have a drink of water, and then after that come back again. Okay, to complete all these 4 pages and get it done with. Okay, so let's start with aphasia. Okay, so main thing what happens here, we have first is common brain lesions here, right? So common brain lesions basically lobe, obviously you have that this thing temporal dementia and all. So inferior frontal gyrus you have Broca's area. Okay, it is supplied by the middle cerebral artery, obviously that portion lateral and parietal and a bit of frontal portion. Middle cerebral artery is only watershed zone, so that's why there we are going to get the stroke. Okay, so obviously, and there is no this thing. Okay, so contralateral hemiparesis, when this frontal, basically frontal lobe, that also comprises of your this thing apraxic gait and all. Okay, now another this thing frontal eye field, this was area 8. Okay, so frontal eye field area 8 do chashma destructive lesion, eyes look towards the brain lesion. Okay, away from the side of the hemiplegia. So this was one important point that time also I had mentioned, that frontal eye field, in case of frontal eye field, okay, it is going to be towards, okay, FT, LFT, we had LFT lacrimal frontal and trochlear nerve. So FT, frontal eye field towards the brain lesion, MCA stroke. Okay, and paramedian pontine reticular formation, PPRF, that is away from the lesion. Okay, that is away from the lesion and towards the side of the hemiplegia. Okay, away from the lesion and towards the side. So basically here, see, hemiplegia will always be crossed. Okay, because your this thing is coming like this, and your upper motor neuron, and then after it is crossing at the level of the medulla, and then it's traveling down to the spinal cord. So frontal eye field, it looks towards the sides of the brain lesion and obviously away from the, because it's contralateral, so it will be away from the hemiplegia. Okay, and this um, paramedian pontine reticular formation, here what will happen is it will look, so this is towards the this thing FT towards the brain lesion. Okay, so that's why it will be away from the hemiplegia, obviously. Okay, see, this will be the hemiplegia, suppose. Obviously the lesion is on the contralateral side here. Okay, so frontal eye field is looking towards the lesion. Okay, so that is away from this side. All right, so that is it. Next is this particular, this thing, paramedian pontine, you have the structure here, you have the, suppose you have the hemiplegia this side. Okay, obviously lesion is in the contralateral side, this portion. Okay, so here what will happen, eyes will look away. Okay, away from this lesion is here, eyes look away. So then that means towards the hemiplegia. Okay, and there'll be seizures also. So this is towards the size of the hemiplegia. Frontal eye field towards the size of the lesion, just remember that. And PPRF you can just infer. Next, medial longitudinal fasciculus, MLF. Okay, so internuclear ophthalmoplegia impaired. This a little bit here, it will be very confusing to mention, but then it will get clear once we deal with that internuclear ophthalmoplegia portion. Okay, so internuclear ophthalmoplegia, impaired adduction of the ipsilateral eye and nystagmus of the contralateral eye with, so ipsilateral may adduction and nystagmus and contralateral eye with abduction. We'll come to this, okay, in multiple sclerosis. This has come before, it is important, very important. Okay, next is dominant parietal apraxia, acalculia, left right disorientation, Gersman syndrome, very important. Okay, I had said also over there. Okay, Gersman syndrome, 2-point discrimination. We can have Wernicke's also, and homonymous inferior quadrantanopia. Okay, so Gersman syndrome is basically angular gyrus. Angular gyrus, dominant parietal lobe. Okay, angular gyrus, dominant parietal lobe, acalculia, Gersman syndrome, acalculia, all that, 2-point discrimination. Even this thing, homonymous, you can have. Mainly this part is main. These things I just wrote down from somewhere in marrow. So just remember dominant parietal cortex or angular gyrus, that is going to be Gersman syndrome. Okay, spatial disorientation, finger agraphia and all that. Next is non-dominant parietal is hemispatial neglect, that clock. Okay, So agnosia, contralateral side of the world. Agnosia of the contralateral side of the world. Hippocampus is anterograde amnesia. Anterograde, okay? Anterograde. Bilateral inability to make new memories. Basal ganglia, obviously rest from Parkinson, Huntington, Wilson's disease. Okay, all that everywhere it is low. And obviously EPS, you have to remember that, and the anti-haloperidol and stuff. Next is subthalamic contralateral hemibalismus. This has come. Subthalamic nuclei, you have contralateral hemibalismus. Okay, contralateral hemibalismus. Next, mammillary body, vitamin B1 deficiency, Wernicke-Korsakoff syndrome, very well given in pixarized confusion, ophthalmoplagia, ataxia, nystagmus, and anterograde memory loss, anterograde retrograde memory loss, confabulations, and personality changes. This is all this thing. Next, amygdala, Kluver Bucy. This is everything hyper, will eat more, have more sex, and hyperorality, also disinhibited behavior, HSV, encephalitis. Okay, visual agnosia, hypermetamorphosis. Next, we have the dorsal midbrain. Okay, so so here in case of dorsal midbrain is Parinaud syndrome. Okay, so this particular this thing, okay, midbrain mein what is the nerve that we have? Okay, obviously the third nerve. And just a second. This is in one of ma'am's crack need series, where basically Parinaud syndrome is going to be vertical gaze palsy. Okay, so vertical gaze is what? Vertical gaze would be superior rectus, right? So superior rectus, dorsal midbrain. What do we have there? Dorsal midbrain mein we have the of the oculomotor nerve. Okay, dorsal midbrain we mainly have the periaqueductal Edinger-Westphal nucleus. Okay, dorsal midbrain. That's what we have over there. Okay, so everything to do with oculomotor nerve, Parinaud syndrome, dorsal midbrain. Okay, so basically Collier's sign, that eyelid retraction is called Collier's sign, and upward gaze palsy, Parinaud syndrome, dorsal midbrain, Parinaud syndrome, dorsal midbrain. Okay, and it basically compresses the superior colliculus. So pinealoblastoma, this is what you have, Parinaud syndrome, pinealoblastoma and pinealogerminoma. There's central calcification, and pinealoblastoma there's peripheral calcification. So gaze palsy is due to all this vertical gaze palsy is due to dorsal midbrain is the this thing only, na, the superior colliculus. So that's what we have. It happens in pinealoma. If there is, we have pinealoblastoma which has central calcifications. Okay, no, pinealoblastoma has peripheral, blastoma has peripheral, and germinoma has central. Just remember, germ cells, they're centermost, and then they give rise to other cells. So germinoma, okay, pineal germinoma, basically pinealoma. So there are two types, pinealogerminoma and pinealoblastoma. So pinealogerminoma is central calcification, and pinealoblastoma is peripheral calcification. So Parinaud syndrome is basically everything to do with the third nerve. So that's a vertical gaze palsy. Okay, and yeah, that is the best way, because LR6 SO4 you don't this thing consider. Pupillary light near dissociation, light lid retraction, that is the Collier's sign, and convergence retraction nystagmus. Okay, convergence retraction nystagmus. Okay, next is reticular activating system. This I don't remember what exactly it is, but okay, forget it. Okay, next is reticular activating system, that is the midbrain. Okay, obviously coma if anything happens to the cerebellar hemisphere, intentional tremors. Okay, resting tremors was in Parkinson's, intentional tremors, limbar texture, ipsilateral deficits. Okay, so this is the only one. Inferior cerebellum, cerebellar peduncle, inferior cerebellar that tract. Okay, so basically that is lesion on the towards the side of the lesion. So ipsilateral deficits. Okay, so ipsilateral deficits. Next is cerebellar vermis. It was centrally, so everything to do with central, truncal ataxia and so on, nystagmus. So this already finished in cerebellum. Next is red nucleus. Red nucleus present at the level of the midbrain. This is important. This is very, 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 very important. Okay. Okay. Actually, this entire table, it has some good stuff. Okay. So decorticate. Okay, decerebrate first. E. Okay. So decerebrate DEE, that is a lot of E, so that's why it's going to be extensor lesion at or below. Okay, and presence with extension of the upper as well as lower extremities. Okay, so here also it is upper extremities, and this is like it can be different. So just remember this one. Okay, so there's lots of E's, decerebrate, so that's why this is an extensor. Okay, lesion at or below the red nucleus. Okay, at or below, right? Extension of both limbs. Okay, and decorticate, we know it's flexor. So flexor for what? Flexion for upper limbs. Okay, flexion of upper, but then upper lesion, flexion of upper limbs. So upper gets more advantage, more preference in deciding this flexor posture, the kind of posturing. So yeah, lower limbs is always extension. Okay, worse prognosis with decerebrate posturing because down, and in because your hands are near your heart. Yeah, obviously this is a good mnemonic. Okay, next is okay, so site of the lesion and obviously cerebellum, all this is done. Next we come to stroke. Okay, so stroke, I'll also recollect the try and active recall the flowchart from MAM's BTR and do that also at the same time. Okay, actually this I didn't read a lot from here. You can go ahead and read it from any medicine, this thing also, but yeah, it is, we can quickly go through this because there is this thing: 5 minutes of hypoxia, irreversible injury, most vulnerable hippocampus, neocortex, cerebrum, Purkinje, watershed areas, vulnerable hippos need pure water. Fine. Vulnerable hippos need pure water. Not really necessary, but yeah, we can remember that Purkinje cells and neocortex. Obviously, NCCT excludes hemorrhage before TCA. Everyone knows this. Ischemic changes is 6 to 24 hours. Okay, and diffusion with MRI can detect within 3 to 30 minutes, but obviously it is not done. But that is the best investigation, obviously, to detect stroke. 3 to 30 minutes में it can detect stroke. So actually BWI is the best investigation, but then you basically have the this thing. Okay, so that is done. Okay, next what do we have? Next another, so quickly we'll just go through the stroke parts. Okay, wait just a second. Okay, another very this thing part. So next is time since change. Okay, this you can just go through it. The reactive gliosis is more important. Okay, that the part that we had in the astrocytes and the reactive gliosis, that astrocytes undergo reactive gliosis. Okay, so that is derived from the neuroactive, all those this thing only, and only what was it, microglia was macrophages. Okay, so stroke ka protocol important. All right, next let's see histologic features: eosinophilic cytoplasm, obviously pycnotic nucleus. Okay, pycnotic nucleus, irreversible, धीरे धीरे you are having the first, this is reversible like said injury. Irreversible, it becomes 5 minutes. Okay, so 12 to 24 hours already become irreversible. Necrosis, neutrophil, macrophage, microglia, vascular proliferation, reactive gliosis, astrocytes, and then finally you have a glial scar. Next, obviously, blockage. You have a liquefactive necrosis, 3 types, okay, thrombotic, embolic. See, whenever they have that atrial fibrillation and this thing also, na, that also can lead on to. Atrial fibrillation can literally go to your eyes also, okay, and it can come to your brain also. So both, alright. So yeah, that is done. And then after that, embolic is obviously obstructing the this thing vessels, so that is important. Embolic stroke, it is this thing multiple, and we had the Jerin de Rusi, that will come, okay, lacunar infarct and atrial fibrillation, all this carotid stenosis, DVT, patent foramen ovale, patent foramen paradoxic and emboli. It comes from basically what, right to left emboli. Infective endocarditis, okay, hypoxic, hypoxia due to cardiovascular surgery, water sweat areas. Next is TPA. Using if within 3.3 and no risk of hemorrhage, it is given within 3 to 3.5, 4.5 hours. So this is like 12 to 20 or 3 to 3.5, so fine. Okay, we had a 4-hour window, right? In the there's a flow chart, okay, 3 flow chart in BTR, MAMS BTR. So 3 to 4.5, that is going to be TPA and a thrombectomy if it is a very large occlusion, and obviously reduce the risk with aspirin and all this, okay. And then this, now the main thing is, I'm just going to read, I'm going to read aloud. I'll take out ma'am's, like I'm just taking out ma'am's notes on stroke, approach to stroke, which is actually very important. So I'll take that out and I'll just read that aloud, okay, because it's very important. Okay, so first we'll do, you have irreversible focal neurological deficits. We do NCCT. Okay, now that NCCT we do to whether there's to see any hemorrhage or not. Okay, so there's a putamen hemorrhage picture. Okay, putamen mein hemorrhage. So we all know putamen. Putamen is what? Putamen. Then we have globus pallidus. Okay, so putamen mein we'll see whether there's. That is a picture that is given in MAMS BTR. Okay. Next we have NCCT, whether there's hemorrhage or no hemorrhage. So NCCT we are doing whether there's hemorrhage or no hemorrhage. Hemorrhage अगर होगा तो कोई therapy we are not going to do. Okay, means we are not going to do the stroke this thing therapy TPA वहाँ पे, और why would we try to increase the hemorrhage? Okay, means thrombolysis contraindicated if there is hemorrhage. NCCT done to find out whether hemorrhage is present or not. Next is no hemorrhage. When you have no hemorrhage, then you have this window. Okay, less than 4.5 hours का window. Alright, LSW. Okay, so less than, that is the golden hour. Okay, so window agar less than 4.5 hours we have, then we do thrombolytic therapy, thrombolytics. Okay, and suppose if we have 4.5 hours to 6 hours, okay, we'll do this thing, we'll do embolize the CT and CTP. Okay, so we do those tests CT and CTP, and then after that we'll see whether there's intracranial thrombus with penumbra. With penumbra agar hoga, means if it is going to be with penumbra, then that means it's salvageable. Okay, then we can consider mechanical thrombectomy or IA thrombolysis. Okay, and if we see that there's no penumbra and the thrombus is still plus and minus, then IA therapy may not be useful. Okay, so that is the stroke ka this thing. Now stroke parameters, BP more than like contraindication to thrombolysis. This is very important. What are the contraindications to thrombolysis? See, all this is not written over here. Okay, and I actually did it from ma'am's BTR. Okay, and it is just one page mein she's given it very beautifully. Okay, so 185 by 110, that is BP. Okay, what are the contraindications to thrombolysis? So contraindications to thrombolysis, we have 185 by 110 ka BP, bleeding diastasis, very important, recent head injury or intracranial hemorrhage, major surgery in preceding 2 weeks. Okay, if you had major surgery in preceding 2 weeks, GI bleed in preceding 3 weeks, and recent MI. Okay, so these are the 4 to 5 paragraphs. So again I'm saying BP more than 185 by 110, any GI bleed, it means GI surgery, GI bleed in 3 weeks. Okay, any major surgery in 2 weeks, GI surgery, GI bleed is 3 weeks, major surgery is 2 weeks. Okay, preceding 2 weeks. Obviously bleeding diastasis you won't give. If there is a history of intracranial hemorrhage you won't give. and finally recent MI. You won't give, okay? Next, these are the contraindications, okay? NCCT again, I'm speaking out that flowchart again. NCCT, you do to see whether there's hemorrhage or not. If there's hemorrhage, you're not going to proceed with the thrombolysis, okay? Because already so much of hemorrhage is taking place. And then, if there is no hemorrhage, then we'll do CTA and CTPA. Okay, basically window. First, we see the window. Is it less than 4.5 hours? See here, we have TPA within 4.5 hours to this thing onset if there is no risk of hemorrhage. So the simple thing is, if it is below 4.5 hours, okay, we have the window period with us to do the thrombolysis, okay? So we just do the thrombolysis. All right, so if this particular, so here TPA, okay, clot, this thing thrombolysis we are doing, okay, because we have 3 to 4.5 hours. 4.5 hours is going to be 4.5. The same thing is written in MAM's this thing also, MAM's flowchart also, that 4.5 hours is your window period, okay? So 4.5 hours is your window period. If the time is less than 4.5 hours and you're seeing that there's no hemorrhage, then you can go for thrombolysis, okay, thrombectomy, thrombolysis. And if the obviously the if it is a very large occlusion, you can go for thrombectomy. But if you have 4.5 to 6 hours, what do you do then? 4.5 to 6 hours, which is not written here. So 4.5 to 6 hours, you do CTA and CTP, okay, that to see whether there's any penumbra, that is salvageable portion or not. If you see that there is penumbra, there is salvageable tissue, okay, intravenous thrombus, then you consider again eye therapy, thrombolytics, or mechanical thrombectomy, okay. But if there is no penumbra, then it is not very useful, okay, to do. Next, another this thing is the fast, okay. So fast ka mnemonic is facial drooping, arms weakness, speech difficulty, and time to call the ambulance, okay. Pronator drift is a important this thing, pronator drift, okay. And those indications of key contraindication, means contraindications for thrombolysis, that is also important. Next is TIA, transient ischemic attack. So obviously brief reversible episode of focal neuro, all this is fine, okay, without acute infarction, okay. So nothing is present in the MRI, okay, and majority resolves within 15 minutes, okay. 15 minutes. Causes ischemia embolus, may present amaurosis fugax, this is transient vision loss, okay, due to retinal artery emboli. I said no, you have this ischemia and this thing and the emboli goes, okay. So arrhythmia, that can be a buzzword clue, okay. Okay, next is this neonatal interventricular hemorrhage. This is important from pediatrics point of view, okay. Pediatrics point of view, it is mentioned in MAM's BTR also, okay. Intraventricular hemorrhage, okay. So basically bleeding in the ventricles, this is mainly increased premature low birth weight infants, germinal matrix, highly vascularized subventricular zone, reduced glial fiber support, impaired BP regulation, altered level of consciousness, bulging, hypotension, seizure, coma. Not very this thing, you can just go through that. Next we'll come to epidural, subdural, okay. So epidural, subdural, these are also very well given in trauma BTR of MAM, not very necessary to read from here, but the only this thing, just let's recollect, okay. So first thing is E, okay. E is idli, okay. E stands for idli, okay. So this is idli shaped, all right. Call it lens shape, but then at the end of the day it looks like a idli, okay. So idli shaped E, okay. E. Now epidural, we saw that terion ke paas there was that artery, okay, your the artery that was passing through foramen spinosum, middle meningeal artery, okay. So here it is middle meningeal artery and here it is bridging veins in case of subdural. There also I had recollected and said, obviously this is a branch of the maxillary artery, everyone know terion thik hai, already recollected. Lucid interval, okay, this is important. Epidural mein you have lucid interval, that is transient loss of consciousness, and this is like important. And rapid deterioration due to hematoma expansion, okay. So obviously hematoma, uncle herniation and all that also you have. Now important, okay, epidural does not cross the suture lines, okay, otherwise it would not have made an idli. If it would have crossed the suture line, then it would have not made an idli. But another thing, it crosses the midline, okay. What does not cross the suture lines crosses the midline. Okay, so that is important. Not cross the suture line, that is fine. Let's see this quickly. Scalp hematoma is also very similar to this only, I think. Rapid intracranial expansion under systematic transtentorial herniation, cranial nerve 3 palsy. Yeah, okay, fine. Oh, cranial nerve 3 palsy, and okay, so basically transtentorial herniation because we have that lucid interval, and cranial nerve 3. Okay, so cranial nerve 3 palsy, cranial nerve 3 palsy. So that's why you see the pupils. This is very important. Surgery point of view, it is very important. So anyone doing, for the profs is actually very important. Profs is, I mean, it means the MB prof. Okay, first for the third prof, fourth prof. Okay, this cranial nerve 3 palsy. Okay, anyways, this is like, it is a significant one. Cranial nerve 3 palsy, that is epidural hematoma, and subdural may obviously bridging vein traumatic hyperdense. All that is okay, and chronic associated with trauma, cerebral atrophy. All this hypotension, CT, shaken baby syndrome, predisposing factors is brain atrophy. Crescent shape crosses the suture lines, can cause midline shift. Okay, acute and chronic hemorrhage. Okay, another important this thing is swirl sign. Ready? Okay, so I'm going for dinner.